Australia, but I'm actually from Devon, and I was trying to count yesterday. I think at least 4 generations of my family have lived their entire life in Exeter. My dad was born just down the road. My grandparents lived in Alphington until they passed away. So this is home for me, and it's really lovely to be back. And I'm especially excited and delighted to hear that Exeter has become the hub of psychedelics in the UK since I left, which is wonderful news. I can't think of a better place. So I'm currently living in the other hub of psychedelics in the world, which is Melbourne. Some of you may be aware that a couple of years ago the law changed in Australia, and it's become the first country in the world to, since Prohibition, to down schedule MDMA and psilocybin from poison that is completely legal to prescribable medicine, so can be prescribed by psychiatrists. And so that is beginning slowly to happen in Australia, but there's still quite a lot of research happening as well. So I'm speaking a little bit today about one of the trials that I'm working on. There's a few trials happening in the psychedelic lab at Monash University, but particularly I'm talking about post-traumatic stress disorder in first responders. And in order to really explain why that's something that's very close to my heart, I'm going to go back a little bit and talk about how I ended up there. So this is a photo that my little brother took with his drone of North Devon, just near where we grew up. So my first psychedelic experience was probably about 20 years ago when I was a medical student in Cardiff University in Wales. I went to the Netherlands like every good hippie student did, and had some psilocybin, and had a hugely transformative experience that I really consider to be a before and after moment in my life. And it was like receiving a very concentrated dollop of insight into the nature of interconnectedness of everything. And it was a huge, profound, life-changing moment for me. And I was really quite sure at that time that psychedelics were going to become a therapeutic option at some point, hopefully in my lifetime, but it really felt like something that was a long, long way off, and I couldn't imagine really how it would look, but I felt like it was something that was probably on the horizon at some point. Felt like a pipe dream, actually, really. So meanwhile, I got on with my other pipe dream, which was working in hospital medicine, working in emergency departments, working in intensive care units, and I had very itchy feet, and I travelled as much as I possibly could, and that took me to Australia in 2012, where I had an extremely hectic time working, lots of horrible shift work, really fast-paced, noisy, stressful, lots of beeping, lots of drama, and it was an environment that I thought I was thriving in, and I found really exciting at the time, but as I later found, it's not particularly sustainable to live in that kind of an environment for any length of time. Part of what I was doing in Australia was working in remote areas. So, has anyone been to Australia here? Anyone travelled around much? Oh, good to see. So, people who've been there will probably know that most of the is there a pointer on here? Oh, yeah, here we are. So, this is the very populated area. This is where Melbourne is. This is Sydney. Brisbane is there. Perth is there. Very, very little in the way of resources for healthcare here. So this is a map of what's the distance to the nearest hospital. So it's quite quick if you're living in the populated areas, but if you're living anywhere else, this will take you almost 10 hours to get to a medical facility. And this map here is about relative access to health professionals for Indigenous people. So it's weighted. Obviously the population is less dense in these areas, but even so, if you're living somewhere like this, your access to health care is dramatically lower, and that inequality was really hard to witness. I mean, I worked quite a bit in this sort of area up here, also up in the Kimberley, and in emergency departments around sort of here as well. And it's really shocking when you go from working here to working here or here, just how huge the discrepancy is in the healthcare that's available to people, the health outcomes, and how well people are, how likely they are to be able to access healthcare that's going to actually help them. Going back to my, early 20s, that experience of really being very, very aware of the interconnectedness of everything, it became quite an ethical and sort of psychological difficulty for me to see that there was just this vast amount of inequality. And also I felt like as a white British person, it was, a lot of what's going on in Australia is a direct result of the colonization. Only a couple of hundred years of settler development in that country has just wiped out the oldest continuing culture on the planet in many places. And I think there's really just not enough recognition of just how tragic and how awful that is. The indigenous populations of Australia are people that have spent sort of 60, 70,000 years living, knowing that the country, the land, is actually part of them, that we're all part of the planet that we live on, and that has enabled that kind of social group to live in an extremely sustainable way. And it's only taken a couple of hundred years of not remembering that to decimate a lot of this beautiful country. So when you zoom out and look globally, it's actually even more stark. So this is a map of the UN Human Development Index, which is a score that's calculated using three things: the life expectancy and access to healthcare. Second thing is how much education you're likely to have, and the third one is income relative to the wealth of the country. So again, you can see that the Anglophone places, great, you have a lovely life. If you're living in the global south, or if you're particularly in Africa, your human development index is drastically lower. So I felt like continuing to work in a place where the majority of people were still able to access healthcare that was good was probably not enough. I wanted to work somewhere where it was more the resources that I had, the things that I was lucky enough to, the privilege that I was lucky enough to have been born into, I could actually give back somewhere more needy. So that took me to this country here, which I actually hadn't really heard of when I was asked to go there. So I was working for Médecins Sans Frontières, Doctors Without Borders, which is a humanitarian NGO that provides medical care to places of humanitarian disasters, conflict zones, natural disasters, and they work a lot in this area of Africa, among other places. But this country, the Central African Republic, it's almost always at the bottom three of the Human Development Index of all countries in the world. Huge rates of infant mortality. I think infant mortality rate is one of the highest on Earth. The maternal mortality rate, one of the highest on Earth. Huge rates of malaria, TB, HIV, malnutrition, vaccine-preventable diseases, and also the problems that come with conflict. So there's been a civil war there since about 2013. This is what this job looked like. So this was the camp that was in the town where I was working. This was our waiting room for the emergency department. This was our mobile clinic. We didn't have running water in the hospital. We didn't have electricity. We had a crap generator that sometimes conked out. We quite frequently ran out of basic things, antibiotics, morphine even. And everyone had malaria, including me at one point. Everyone, it was just impossible to not catch it. This was one of our wards. It was made of it was a tent, so it's pretty sweaty in there. And yeah, this was our emergency department. We had two little rickety beds. It was just the resources. I can't describe how low they were and how that really affected people. So it was 6 months working in this environment, and then my job was up, and I came back to Australia. And this is where I worked next. This is the Sunshine Coast University Hospital. It had just been finished being built when I arrived, and I think it cost $2 billion to put it together. And we had this lovely emergency department with CT scanners attached to the individual resus bays. You could just wheel the wall back and roll someone straight into a CT scan. And we didn't actually have I don't think there was a single CT scanner in the entire country of the Central African Republic. Certainly wasn't anything like ventilators or any of that equipment. So I had quite a hard time adjusting to coming back to this place, and found myself in a pretty dark place. MSF is really they take a lot of care of their people that work for them. And when I left the Central African Republic, it was there was a certain list of countries that you had to see the psychologist when you come out. There was, I think, Syria, Yemen, Iraq, Afghanistan, and the Central African Republic, which were considered to be the most difficult places for working at the time. And so on debriefing in Paris, I had to sit with the psychologist and have an assessment. How am I doing? Am I all right? Can I go back home? What's going on? And I remember looking at this poor woman who was about 25 and thinking, I can't inflict anything on you anything that I've witnessed. I don't think you're going to be able to hear it, and I don't think you can do anything about it. So what's the point? And also, I'm fine. I'm all right. So does anyone know personally any first responders or anyone know paramedics, police, anyone like that? Yeah, they're very good at being fine. And I mean, part of the job really is to be able to switch off your emotions, to be able to turn off the normal human responses to the kind of things that you have to see in your day-to-day work. Part of doing that is putting on your uniform, putting on your work identity. You have a persona, you've got your hat on, and off you go to work, and you do your role, and any normal human reactions that you have to the things that you have to see, you put them in a nice little box with a lid that you can slam down and just keep it out of the way of everything else. And I don't think I've ever met anyone that works in emergency medicine or humanitarian medicine or anything of that ilk that has a method too wildly different to that, because I just don't think it's compatible with, you can't feel the normal responses to what you're seeing in the moment, and generally you have to really reserve them for some kind of time that's well away from your work, because it does just make the work impossible. And over time, I think that can really become quite a calcified process where you sort of begin to lose access to those things that you've walled off. They become further and further away. They become more and more unreachable. And you get more and more disconnected from people that are around you. And if you find yourself having dealt with something that's particularly impossible to manage, finding a way of communicating it to someone is very, very difficult. Even the most well-meaning of, I think professionals, if you get a sense that it's not possible for them to really understand what you mean, then it's quite a hopeless situation. So this picture of a well, has anyone heard of an oubliette? Anyone know that word? It's a really horrible thing that they used to have in medieval prisons. It's like a horrible tunnel. They would just chuck people in there and go, right, you're finished. Yeah, and it felt like that was actually where I'd put myself, where I'd put parts of myself that I wasn't able to continue carrying, on the surface, and actually finding my way back up out of there, pretty much impossible. There were well-meaning people that tried to contact, in that space, and I remember thinking, I would love to be able to relate to you. I would love to be able to share some of what I'm carrying. I actually just don't know how to articulate it. I don't know how to translate it. I don't know how to convey any of this in a way that I genuinely know that there's resonance on the other side. And I think that experience is central to the development of post-traumatic stress disorder. I think if you are able to feel like you're connected, like you're held, you're witnessed, you're in a shared experience with what you're going through, you don't end up in this really sort of stuck space. But I think for a lot of people, it's far too late by the time you actually find yourself in that state. So the reason I'm telling you this story is because I think that it's really important to understand with psychedelic-assisted therapy for this, the psychedelic medicine is not the medicine. It's an adjunct to allow reconnection, to allow that thawing of this deep freeze and to get you up the ladder and out. And I think there's sometimes a little bit of difficulty in understanding what the role of the drug is. I think MDMA is quite a particular special substance in many ways. And I can talk a little bit more towards the end about, if I have time, about why that's the case. But it's the relationship with your therapeutic team that is the healing medicine. It's not the drug. The drug just facilitates it. So here's what modern psychiatry thinks about PTSD. And I've made this slide deliberately very visually offensive and noisy and ugly because I find that that's what the DSM is like in a lot of ways. Here's a list so here's what the DSM considers to be post-traumatic stress disorder. It's different if you're using the ICD-10, 11, whichever one. And then there's a distinction as well between PTSD and complex PTSD. And then there's a lot of arguments about, does complex PTSD, is that a pseudonym for borderline personality disorder or all these other things? And the treatment approach for PTSD is, the central one is obviously trauma-focused therapy. So EMDR, cognitive behavioral therapy are the two that are recommended where I'm working in Australia. But again, not many people can afford the amount of therapy that you really need to adequately treat post-traumatic stress disorder. And I think a lot of people are not able to tolerate what the therapy involves, and a lot of people are not able to stick out the long course that's required. The other mainstay of treatment is medications, SSRIs, SNRIs, benzos, things to help you sleep, things to help you stop feeling so panicked, things to block the nightmares, all that kind of stuff. But really, all of that is palliation. It's not about cure. You don't cure anybody with things that just take the edge off the symptoms. So I find it really quite sad, really, that at the moment with what we have is not particularly adequate, not particularly effective. So I think statistically about a third to a half of people with PTSD have it for a chronic amount of time, so at least a year, sometimes longer. And actually what we're seeing with the participants that are coming through our trial, many of them have had severe post-traumatic stress disorder for a decade or more, and without really any trajectory of recovery on that. They're in the state, they stay there. And so the trial I'm working on, it's called MMP1. It's a trial that we designed at Monash University. It's designed for first responders, so we're including in that. We can be a little bit flexible with who we consider to be a first responder, but it's the majority of our participants have been police, paramedics, fire, a couple of military. I think we've had some healthcare workers, nurses, people that have, I think particularly in Australia, there was a very huge amount of trauma from COVID, and people that were working in hospital medicine when there was that big wave of COVID that put a lot of people on ventilators, and a lot of moral injury from there. But I think also first responders, anyone in a sort of public-facing role, so I would also really include in that, not for this trial, but I think, social workers, education workers, people that have to come face to face with the most difficult things that humanity has to offer, and have to not have the normal human response to it. So if you're contacting extreme violence, if you're contacting, child abuse, all of these awful things that people have to face in the line of work, there's a huge risk that you're going to end up with a sort of walled off pile of things that you aren't able to manage. I actually heard a really lovely term a couple of days ago in one of the talks which was the concept of the indigestible lump of psychic experience. I think it was Tim Reed that said that in his talk with Maria about dyad work. And I think that describes really well what I was carrying. Something that it couldn't be metabolized, it couldn't be dissolved. You couldn't do anything with it, and that's really what we're seeing. A lot of our participants in this trial have. They're disconnected from themselves. They're disconnected from their emotions. It's not safe to feel them, and also that I think goes hand in hand with real disconnection from others and from a sense of meaning in your life, from a sense of purpose. When I came back from my MSF work, I didn't have. I mean, I was very lucky actually it took me a couple of years to realise that I should stop working in emergency medicine because it was going to do me in early. But it was. I was very fortunate to be in a position where I could, take a bit of time out. I could reconsider. I could decide on a career change. I could afford to put myself through as much therapy as I wanted to do, but psychedelic-assisted therapy wasn't an available treatment for me at the time, and so I had to find a different way. I knew that it was important to bridge that gap and to try and articulate and narrativize some of what I'd been through. So the way that I managed that was writing, and that was really helpful. But for a lot of people, that's not something that's in their kind of toolkit. So I decided to start working in mental health, and to my massive surprise and joy, a couple of years ago, they decided in Australia that they were going to be the first country to start working in psychedelics. So I happened to be in the right place at the right time. It was really good. And the first trial that I was able to start working on was this one that I happened to have quite a lot of personal insight into what it's like. So. My feeling is that PTSD, it's I think we're approaching it wrong in a lot of ways. It's not an individual disorder. It's a disorder of an individual nervous system trying to hold something that belongs to the collective. And I think that's nowhere is that more visible than in first responders, who are the people that have to face the things the worst things that we've got in our society, the worst things that we've constructed in this way of living, and their job is to kind of shield everybody from it. And then we can to pathologize the person that is, manifesting the result of that experience, and say that they're the one that's broken, they're the one that needs to be, considered sick. I think that's a misplacement of responsibility of understanding. I think it's actually important that we recognise that individual trauma is part of collective trauma. There's, in the same way, there's no such thing as individual healing. I think if one person heals, that actually is part of healing of everybody, which is why I'm so passionate about this work, because I think every single person that we can improve here. Anyone who's known somebody with PTSD, and there's a lot of people that after the Second World War who came back with PTSD, those experiences ripple down through generations. And if you can actually just help a single person with this, the reach is enormous. The ripple effect is huge. So I don't have a huge amount of time left to talk about the trial, but if anyone's... this is the lab in Melbourne. Some really wonderful, wonderful people. This is Paul Licknitsky. Some of you might know him. He's the fellow that set it up. This guy, I'm pointing him out because I'm about to show you a weird drawing that he made after a dose session once. But yeah, they're brilliant people. Here's some information about the trial. I can go back to this later if you want to see it. It's the treatment timeline. It's 18 weeks of treatment. So there's 26 participants that we're recruiting altogether. Is that right? 24, beg your pardon. We're using a dyad model. We're using a dose of 160 milligrams total on dose day. There's 2 dose days, 8 weeks and 12 weeks. And this is the preparation, so 3 preparation sessions, dose 1, and then 3 integration sessions, dose 2, and then 5 integration sessions, and that's the primary endpoint. And then we also do a repeat long-term follow-up at 30 weeks after the start. So here's Joe's picture of how MDMA works. He likes rainbows. MDMA, it's, as I say, it's not the medicine. It's the thing that facilitates the healing relationship, the reconnection. And the reason I told you so much about, you know, that huge distance that I felt when I was at the bottom of this oubliette type experience is, these are all things that MDMA is well known to induce. This is why people take it recreationally, why they have such a great time. But in the setting of therapy, all of this shrinks the depth of the well, and it really helps you to actually form that important connection that is the bridge to being able to, you know, go in and through. You have to be able to feel your emotions. You have to be able to actually metabolize them for them to stop haunting you. This is we haven't finished the trial yet, so I can't speak too much about the results, but this is an N of 1 that I just wanted to share, and this is reasonably typical of a lot of the results. So this person, at the baseline, CAPS-5, it's a checklist that you can use to measure severity of PTSD. This person had a score of 34, which put them just on the threshold between moderate and severe PTSD. This person had had about a decade of severe symptoms. They hadn't been able to really leave the house. They felt, you know, profoundly disconnected from a lot of people in their lives. And so this was 6 weeks after the second dose. The score had reduced down to 12, so only just within the mild PTSD bracket. And then long-term follow-up, so that's 27 weeks after the treatment start, 18 weeks after the end of dose 2, and actually several weeks after the end of the therapy, score was now 8. So basically in remission. And this is one of my favorite things about seeing this is people get better, and then even once the trial's finished, once they're out of treatment, they actually continue to get better. And that is because this is not the medicine that's helpful, it's actually getting people out of that stuck, isolated place and being able to reconnect. Here's a small plug for the training that we're doing at Monash University. If anyone's interested in our graduate certificate in psychedelic therapies, which you can do online, here's the QR code for it. And tiny final plug, here's the book that I wrote to metabolize all of the awful stuff that I'd seen, which is going to be published in a few months. So hopefully we've got some questions a bit later on. There's a panel discussion, I think, at 11 o'clock. Yeah, so thanks so much for listening, and see you later.